Yes, American, and a very good afternoon, everyone. Sorry, as we started a bit late because we have Prof also have problem to join us because of the participant is reach more than 300 participants. Okay, so first of all, I would like to welcome to all of you for our monthly Meets the Expert, which organized by ONG departments, Sultan Ahmad Shah Medical Center, Sasma AIUM. So before we start, we'll start our session today with recitation of Ummul Kitab Al-Fatihah. All right, so let me introduce myself. So I'm Lisha, will be your moderator for today's. So the topic for our MTE today is a second stage CTG. For those who are involved in delivery, always had dilemma with the CTG. We know it is vital to determine whether the fetus is exposed to intrapartum hypoxia to ensure timely and appropriate management, whereby if we fail to interpret of the fetal heart rate correctly during the second stage in labor, it may lead to increase of maternal and neonatal morbidity due to unnecessary cesarean sections and instrumental delivery. However, delay in timely and appropriate interventions can also result in increased perinatal morbidity and mortality. Thus, our expert speakers today, Prof. Imelda, will be the most appropriate person to discuss regarding our topic for today, which is second stage CTG. Right. Prof. Imelda, are you okay, Prof?
Hello.
Yeah,
Apa
Prof.
khabar semua? I just want to thank you so much, Lisha. You know, I'm not a prof anymore.
Okay.
I have left my position as professor in University Malaya, and it's not right to abuse the. I say it's not right to abuse the title and keep calling yourself prof if you have actually left the position, academic position. Unless when you retire, they give you emeritus professor, kan? So you can use professor title for life, but not if you're no longer a professor. So you just call me Dr. Imelda, that's fine, all right? So Lisha, thank you for inviting me. I'm sorry for the delays because we had deliveries. This COVID situation is not ideal. But you know, we make with what we can do and take every opportunity to learn new things, kan? So I just want to find out from the audience and participants, are they all doctors in training ke, nurses ke?
So all our participant is doctors, and also some of them is actually staff nurse.
Staff nurse, okay.
Yeah.
So welcome. So we're going to start off. Did you start off with a quiz?
Yeah, true, Prof. True, Doctor. Sorry, true, Dr. Malaysia. I already.
Yeah, kita, you know, I suka interactive session because this is what I always do to all my trainees, so that they can ask questions at any time. Are we able to allow them to voice out? I'm quite happy for people to interrupt and ask questions when they don't understand anything, because you know, kalau tidak kita rattle on, it can be quite boring. I cakap sorang-sorang je kan. You know, like reminds me of Dora the Explorer, right? You ask the question, then diam, and then you jawab sendiri.
But I think for all the participants who want to ask questions or talk about some things, we can allow to unmute them.
Yeah, I think it's good, more fun that we unmute so people who want to ask questions can ask, and you know, it's more fun to have a two-way interactive session than just me talking, kan?
Yeah, true, Doctor.
Yeah. So then we can start with the quiz, and then we work from that. I do have slides, but I think it's very boring because our normal interactive session is not there for slides. But what we'll do is we'll go through the quiz, and then we have you can invite participants to talk and ask questions whenever you want to.
Okay.
Okay.
Sure. Okay, Doctor. All right, so without further ado, I would like to invite you all to type jointhequiz.com and insert the code numbers as been stated on the screen. So wait for a while. So for all participants, please join us by type jointhequiz.com. Okay, wait for a while for our code numbers to be shared in the screens. All right. Okay, so all of you can see, right? So just type joinmyquiz.com and enter the game codes 540706. Okay, so no worries, there is no right or wrong answers. So later, this case, all these cases in this case will be discussed for our case presentations. Right. So all the participants, please participate with our quiz. Just type joinmyquiz.com and you will go to the websites of quizzes.com. Just enter the code, game codes 540706. Right, so we already have 29 participants. So we have actually 300 participants for today, which is the highest participant for our MTE.
Well done.
Yeah. Right. Very good, Prof. Doctor, sorry. Okay, so far we have 68, 70. So we aim for maybe if 100 or 150, half of us join our quiz.
Okay, well sambil kita tunggu orang nak join, kita boleh sembang-sembang sikit. Alright. So siapa nak unmute boleh kan?
Boleh, Doktor.
Boleh je. So amongst the group ni, how many people yang buat MOG pathway and how many buat MRCOG pathway? Ada tak siapa MRCOG pathway?
So any for the participants?
Macam mana mereka nak jawab?
They can unmute themselves.
Tak ada siapa pun MRCOG pathway. Oh, siapa yang buat emoji? Some people buat emoji dan MRCOG. Oh, okay. Ada emoji kat situ.
So they prefer to type, Doktor.
Okay. Okay, nanti Sat, I got a call from hospital. Give me a second.
No problem, Doktor.
Hello? Yes. Tak boleh, I'm starting my tutorial. Is it emergency? Urgency? Untuk siapa? Aini. Okay. Tak boleh kata I'm not here. You have to wait until I finish my tutorial. I'm giving 300 people.
I think we will wait for Dr. Imelda first. Maybe she's also want to join us with our quiz. So far we have 163 participants. Well done, everyone. All of you are very alert in this lovely evening, Friday evening, after our lunch. Okay, some more. We have 300 actually, and also we also have those watch us from live streaming Facebook. Okay, 168. Okay, Doctor, I think we can start. Dr. Imelda, because I already have 172 participants to join.
Okay, I'm back.
Okay.
Okay.
Right,
so when we start our quiz, all right, if there is any questions you want to ask, you boleh je menyampuk, okay? Kita you learn best if you ask as you think about it, because kalau you tunggu lama-lama you lupa nak tanya.
Okay, alright, that's good. Okay.
Okay.
Okay, so I think I would like to pass to Dr. Mumtaza to start our quiz.
Thank you very much.
Okay, Bismillah. We'll start our quiz right now. Ready? No more? Okay, starting. First question. 28-year-old primary gravida at 39 weeks 6 days admitted for PROM more than 24 hours. Baby was clinically 2.8 to 3 kilo. Assessment at this CTG was osculi station +1, very absent, clear LIPA, all 8 LOA position. So based on this CTG, what do you want to do next?
Okay. I nak buka this to anyone who want to volunteer and answer. What would you do next? Anybody?
Most of them say vacuum assisted delivery.
Siapa cakap? Siapa yang cakap tu?
101 participant.
Depa kata, oh, that one, vacuum assisted delivery. Okay, can we go back to that CTG? Somebody, 5 people said cesarean. How many said continue monitoring? 3 continue monitoring, and then last kali allow what? I cannot see the 4th one.
Oh, yeah.
Was that allow normal birth or something? I cannot read that last part of the graph. Well, this is okay, good, very good. Allow passive second stage. Right, so 100 people say you want to do vacuum assisted delivery. Okay, so aren't you going to assess first? Aren't you going to assess first if to see if delivery is already imminent?
Yeah.
What is your answer to this?
So yeah, Prof.
Can
Sorry,
we
Doctor, because
can
from
we
the written
make
examination
the
itself,
can we
it
make the
shows that the
CTG
station
screen
is
bigger?
+1. However, there's no abdominal examinations in terms of the engagements of the baby.
Kan betul kan?
So I think we need for assessment abdominal examinations, and also from the
Very
written
good.
examination itself, is actually this patient is suitable for
Yeah,
vacuum assisted
fantastic.
delivery.
So what we want to do is, can we make the graph a bit bigger, the CTG, so that everybody can magnify, zoom in on the CTG.
Prof, sorry, Doctor.
Zoom in on the
can't hear
CTG.
your voice because of
Oh, you can't hear me?
Sorry, Dr. Imelda. We can't
Can you hear me?
Your voice.
You can't hear me? If I'm not mute at the moment. We can hear. Everybody can hear.
Okay, sorry, my mistake.
Okay, so what we want to do is we want to enlarge and magnify the CTG. Can we do that? Good. Okay. Now, what we want to see is, okay, if you're called at this stage, right? Very good. Okay, so when you're called at this stage, sometimes we just get called and we see a CTG like this. You have history ruptured membranes for 24 hours kan? Okay, and then the first thing you want to do is Dr. C Bravado. Can somebody tell me what Dr. C Bravado is? We just want to volunteer. Ini kita start soalan senang tau. Saat ni jadi susah. So yang senang-senang tu cepat-cepat jawab.
So, siapa volunteer nak jawab? Participants, anyone volunteer?
Okay. So I selalunya, yes, very good. Muhammad Iman Dudin Sapi kata define risk. Okay, Andrew Tan, well done. Contraction, baseline heart rate, variability, acceleration, deceleration. What is O? The last one. Dr. C Bravado ada O at the back. Overall, very good.
Overall impression.
Overall, well done. So we're gonna start first with define risk. What do you think this person's risk is, this patient? From the history that we got from about the patient.
She is primary gravida.
Yes, exactly, from more than 24 hours. So the first thing we need to know, is there a picture of chorioamnionitis kan? And whether or not this patient has been given antibiotics. If you have from 24 hours, don't you have a protocol in your hospital? When do you start antibiotics for prolonged SROM? Ada tak in your hospital?
Anyone from participants? From SUSMEC is we will start antibiotic after 12 hours, doctor.
12 hours, brilliant, because ada Cochrane systematic review that shows that when for term pregnancy, yeah, some hospital 18 hours, betul. But the Cochrane systematic review say, remember when you do your exams, you have to have evidence-based. And the Cochrane systematic review shown that 12 hours or more from STROM for term pregnancy, antibiotics prophylaxis, okay, has been shown to improve outcomes and reducing chorioamnionitis and endometritis in mom. So even from 12 hours, if you follow the evidence, even from 12 hours to start antibiotics, you're not wrong. If you think that person is GPS positive, you want to start antibiotic as soon as you know there's STROM, kan? Ataupun so we could start antibiotics. So sometimes when you define the risk and you see the picture, immediately you want to know in your mind, right? Is antibiotics been given? Is there a picture of chorioamnionitis or not? But when you know you're fully dilated, then you know, yes, you know, kalau fully dilated, you know, lega kan? Then you can, the management means you can deliver this baby quite soon. So you dah define the risk and then now you nak tengok contraction. Can someone tell me what is the rate of contraction? Very easy question.
So open to the participants to answer. For intent from Zawani Zainul.
Betul ke? 1, 2, 3, 4, 5. I count 1, 2, 3, 4, 5. About 5 in 10, yeah. So then bila kita tengok 5 in 10 contractions ni, kita nak tahu, is this a normal progression of labor or is this patient been augmented with syntocinon or not? Do we have any information? No information on that.
So
but you will ask that question, won't you? Because you are the person in charge of labor room. You need to have an overall picture. When you manage a CTG, your decision making has to be an overall assessment of the patient, not just the CTG. So these are the questions you need to ask. Because kalau syntocinon contracting 5 in 10, you are not giving enough time for the baby to rest in between contractions. Okay, and you are more likely to have, hyperstimulation type effect. And then the easiest thing to do is to stop the contractions kalau you kata CTG is pathological. So you got to assess, is the CTG, right, normal, suspicious, or pathological? We are looking at it from the point of view of FIGO classification and also from NICE guidelines of intrapartum care, UK punya NICE guideline. MOG belum buat guideline lagi kan? KKM belum buat guideline untuk CTG lagi kan? So we don't have a choice kan? Kalau KKM tak ada guideline, then we have to look at guidelines from overseas, and one of them is FIGO dengan NICE guideline, almost the same. And then, so that is the best for us to refer to. We should refer to and make this an evidence-based management. And then when you write down in your notes, you got to write down why the reasons you intervene. You tak boleh kata CTG tak cantik, tak boleh kata, tak elok, CTG tak normal. You got to be more specific, because when in your training, you are systematic in your specific, and then you carry through this habit as a specialist, then it makes it very, very easy in your future being a specialist. And then, so systematic number 1, Dr. C bravado. Okay, kita dah define risk, we see the contractions 5 in 10, and the first thing we want to know, is she on syntocinon or not? All right. And then the other thing, so you're going to see the baseline heart rate. What do you think a baseline heart rate is?
So everyone, what you all think about the baseline heart rate here? So this is 60, 80, 100, 120, 140. So 130 baseline heart rates, I would say.
Yeah.
Yeah.
I agree with that. Lepas tu, the next thing kita nak check ialah variability.
Okay.
Variability dia berapa? Are we happy with the variability?
I think for the at the first parts of the about 20 minutes of the CTG, the variability is quite acceptable. It's good.
Yeah, apa? So the next thing we want to know is it normal variability? So normal variability has to be
5 to 15 bits.
correct. Up to actually 5 to 25 considered normal variability. So we are quite happy with this variability kan?
Yeah.
But betul. And then my question is, apa yang spiking to about in between? Is that, do you think those are accelerations or do you think those are actually the baseline heart rate? What does everybody think?
So
Kan you tengok everybody seem to say baseline heart rate is 130. So do you actually think, right, when the heart rate goes up to 160, 170 tu, that is acceleration ataupun that is actually the baseline? What do you think?
everyone, anyone to answer?
I'm actually, talking as I speak. I've never seen this CTG before. Okay, somebody mentioned shouldering. Okay, Zurina, that's a good try, shouldering. Possibly right. Tapi shouldering ni selalunya a very fast spike, They don't last for about like 15 seconds like that, no? Reflex tachycardia after deceleration, that possible. So you're saying that this is the baseline actually? Yes, good one. Amir Zakwan Yusof, thank you very much. Need to see today's baseline heart rate. Yang
selain My Sejahtera. Berapa orang? 2 orang? Saya je.
apa tengah cakap tu? Right, so we've got a very good answer there. We need to look at previous baseline to actually be certain what is going on. Kalau kita tengok CTG macam ni saja tak cukup for us to assess, even as no matter how good you are as a specialist, you tengok sekerat macam ni, kita akan rasa tak puas hati. We want to scroll and see the CTG before that to be certain that there is no rising fetal heart rate baseline and then followed by deceleration. Because what determines if the deceleration is a concerning feature, ialah number 1, right? Does the deceleration return to a normal baseline or not? Tu sangat penting. Secondly, does the deceleration return to a normal variability? All right, because if they does not return to a normal heart rate or does not return to normal variability, this is a baby in trouble. What more in trouble? Kalau dia deceleration ni return to normal baseline and normal heart rate, okay, then that is not enough for me to say that this is an abnormal feature for deceleration. Okay, and the other thing you want to know is the deceleration siapa ambil referral kita heart rate berapa? Itulah kan, kena tanya ni semua. So kalau kita tengok the deceleration itself, the first thing we want to know is, are there deceleration happening with every contraction or not? Betul ke tidak? Am I seeing deceleration with every contraction?
I would say
Betul
yes.
kan? I'm seeing that, yes. So betul. So this like 100%, kan? So one feature yang kita nak tahu, yes, more than 50% is what we want to know. That's a good answer. Because if we look at FIGO and NICE guideline, what is a deceleration of concerning feature? Number 1, it is occurring with more than 50% of the contractions. And you can see, yes, it does. It's about 100%. Secondly, it's been ongoing for 30 minutes. Okay, kalau tak sampai 30 minutes lagi, baru je start. In the last 10 minutes, ada deceleration more than 50% contraction. Kita baru kata this is not yet pathological, right? It's not yet an abnormal feature for deceleration. And then thirdly, kita nak tengok dia punya drop in baseline heart rate. Okay, what is concerning in terms of the drop in heart rate from baseline for deceleration? Can somebody answer that question?
Anyone answer?
Yep, betul. Hairi duk jawab macam-macam question. Bagus dia.
Sangat positif.
So you see, it's so much more fun if I can see faces in front of an audience, but this will do. But you see, 60 beats per minute also is an important feature. Here we don't see a drop of 60 beats per minute in the first half of the CTG, but the second half we're starting to see a bit more concern, kan? So when you have 60 beats or more, and then the other thing is whether or not reduce variability in deceleration. Tapi deceleration dia tak lama, kan? Deceleration dia sekejap saja, so you cannot have time to see deceleration within the we reduce variability within the deceleration. But you know, the other thing, good thing about this is that the deceleration recovers within 60 seconds, kan? So you got that 1 minute thing. So number one, is the deceleration recovering to normal baseline? Yang tu kita tak sure at the moment because we tak tahu what's the previous baseline. That one is the missing information that we have. Second, is it recovering to normal variability? I'm seeing normal variability. Okay, and third, is it more than 60 beats drop? Is not. Yeah, so seem to have dropped. So dari kalau you kata 130 tadi, then it's not. Kalau you kata the baseline is actually higher than that, then it is a big drop. Okay, and then secondly, is it taking time to recover? So their recover is quite quick, within 60 seconds. Okay, and then and it's not prolonged deceleration, kan?
Yeah.
So now kita nak tengok, right? Whether do you all going to say this is normal, suspicious, or pathological? So the only thing kita tak tahu is the heart rate. So you know, I suspect that they are not accelerations because you know it's very unusual for you to have accelerations with every contraction like this. This is not normal, kan, kalau kata this acceleration, kan? Secondly, kalau you kata shouldering, okay, that is possible. Shouldering reflex tachycardia and then it goes back to a normal baseline heart rate. But again, we are worried because this is not a deceleration that recovers to a normal baseline when it shoots like that. There is some features there that we are concerned that baby is trying to compensate. There's some compensation effect, a reaction towards the deceleration. And then, so what would you say? Is this normal, suspicious, or pathological?
Anyone? Any comments about the CTG? The overall comments of the CTG? So does it pathological or it's normal or anyone? Suspicious. Suspicious. Okay, most of the participants.
Yeah. Actually, I pun agree tau that it is suspicious. Pasal kita tak tengok the CTG long enough, kan? Kalau tengok this trace saja, you don't see the bigger picture. You don't know what it was before. You can say that this is suspicious, and I think I agree with that. There is not enough here for me to say it's a deceleration concerning feature. But I'm concerned kalau you are still on syntocinon right now, because we would still want to stop that syntocinon, kan, because these contractions are so frequent.
This patient basically not on any oxytocin.
Not on anything. Okay, fine.
Spontaneous level. Yeah.
Yeah. So kalau if on examination you find that this CTG is suspicious and the baby is already deliverable, yes, I do agree to proceed with vacuum, because kalau you tunggu lama-lama, it depends lah. Kalau dia already, you know, visible and about to push this baby out, then, you know, by the time you get your kiwi, you turn around, baby is coming already. Anyway, you'll be too late. But it's always good to have your kit on standby in case this mother becomes too tired to push. So if you see that the head is already at the perineum and it's not going to take long for the mom to push this baby out, then it's not necessarily to do an assisted vacuum delivery. But if you think the mom is struggling and there is still a way for the baby to deliver, yes, to get everything ready and, you know, to try and get this baby out. So that's a very good answer, everybody. Tepuk tangan.
So, but Doctor, there is
What is the other results tak? Dia punya pH for this one.
actually we are planning to discuss all
Okay, fine.
after the this quiz, Doctor.
Okay, good. So kita move on.
I will show the CTG prior to this CTG, and also we will discuss what will happen to the patient after that.
Okay,
After
bagus. Next.
But there is a comment from Amira Anis. Second half
Okay.
of the CTG is poor tracing. Can we comment about the CTG at the poor tracing part? In the about 20 minutes prior to delivery, there is a we can say that this is poor tracing CTG. Can we comment about it?
At the second half of the CTG.
Yeah. Any comment? What? Okay.
Yeah, sounds right. Kan? Dewan bersalin. Siapa Dewan bersalin ni? Yeah, that's true. Once you see the second half of the CTG, you nampak that jagged line going up and down. And the contractions, you don't see contractions anymore, not proper contractions anymore. She's bearing down. And then you find that the probe for the toko aspect there's a lot of pressure on it. So you can see they're high at all times. That this is a sign that the mother is already bearing down, and you lose a lot of contact from that. So patient restless, possible as well. But something that it's if you are actually doing a vacuum delivery or patient is bearing down, then you see a lot of loss of contact. Kepala dia nak turun kan, and sometimes you got to follow the heart going down, and you get loss of contact. And when you get loss of contact, sometimes you get doubling of the CTG. They cannot pick up, and then kalau pick up maternal heart rate, so it could be the maternal heart rate that is sitting at 80 kan. So it could be maternal heart rate that's being picked up, and then after that there's doubling right up to 160. So some CTG machines are not very clever. So when it's so low, it will try to double it, and so you see macam ni lah, bawah atas, quite confusing. They may not necessarily represent fetal heart rate.
Okay. Right. So there is okay. So there is a question here. How long can we allow the bearing down CTG, Dr. Imelda? So how can we allow the bearing down CTG with its?
Apa dia definition of bearing down CTG? I tak tahu apa bearing down CTG makna dia. So the question is, what do you mean by bearing down CTG? You mean like when a mom starts pushing? So if the mother is starting to push, you want to continue CTG until the baby is born. Bearing down means pushing stage, active second stage. You continue the CTG until the baby is born, then you take it off. So from this CTG, you can see toko has been removed already. The last 15 minutes blank, right? Tapi dia punya heart rate too has not been turned off or something. That one is continued. So, but the thing is, continue CTG until baby is out. That's the answer.
Right.
Or unless the question is how long can you allow the CTG before you deliver? I'm not quite certain question there.
I think maybe what he meant is how long should we allow this kind of CTG, poor tracing CTG?
Yes. So the poor tracing, you mean? How long can you allow poor tracing?
Yeah,
Such poor tracing difficult to interpret.
may complicate.
May complicate second stage decisions. You are right. Tapi so what we do, your decision is already made. When you saw the first 20 minutes kan, semua orang kata nak buat vacuum delivery kan. Your decision is already made based on that CTG before they start pushing kan. When you examine their os fully dilated. Decision is already been made. Then you continue with your decision until the baby is born. But you continue the CTG. Kalau tak dapat monitoring, you just got to deliver the answer. The answer to the question is if you cannot monitor heart rate, you have to deliver. And apart from CTG during second stage, what was the question again? Should we continue to?
Should we document fetal heart rate after contractions every 5 minutes as recommended by NICE and NICE guideline? Apart from CTG during second stage.
Okay. You're talking about intermittent fetal monitoring using the daptone.
Yeah.
Okay. Now, NICE guidelines, there are two different pathways. One is monitoring for the low risk pregnant mothers in labor. That one, they allow intermittent fetal monitoring, tak pakai CTG. All right. So for that, for NICE guideline, these are women who are being delivered by midwives. So there is no campur tangan from medical officers or doctors. And they are delivering either in home birth. So in the UK, they allow low-risk mothers to choose whether they deliver in a high-risk setting in a consultant unit. This is for women who would want to have epidural. Okay, the low-risk mothers are also given the option to deliver in midwifery-led units where there are no doctors, but this midwifery-led units can be a stand-alone unit ataupun in a building next to the ONG department ataupun at in front of the corridor of obstetric, high-risk obstetric unit. And then there's also midwifery-led home birth. So these low-risk pregnancies, they are allowed to have intermittent monitoring. So they usually use daptone. So in the first stage of labor, you want to monitor every 15 minutes and they must document what is the fetal heart rate every 15 minutes. So they have to document in the notes, okay? And then they have to monitor for 1 minute after a contraction. So there's a lot of documentation that has been done by the midwives. Then in the second stage of labor, when the mom starts active pushing, that will be every 5 minutes. Let's say baby's outcome is poor. Will that CTG influence our outcome? How do you know what the baby's outcome? The baby's not born yet. So you're basing your decision in retrospect, tak boleh lah. You got to do your training in, prospectively. Now you're seeing this patient like this, and then what you're going to do about it. So, when to answer the other question, so CTG monitoring in second stage of labor in low risk pregnant women, they have to do it every 5 minutes for 1 minute after a contraction. So that's actually quite a lot of work for the midwife to do, and they will have to document it. So don't confuse the intermittent monitoring from full electronic monitoring that we are doing now, which is the CTG. All right, so CTG in Malaysia, we tend to do it for everybody, even though they are low risk. But in the UK, they don't do CTG for low-risk mothers unless something happens during labor and they become high risk. For example, if they develop pyrexia, they have meconium, mom's heart rate goes up, becomes tachycardic, or moms develop hypertension, or you detect with a daptone abnormal CTG fetal heart rate pattern, you detect decelerations, then you got to move on to using the CTG and move the patient to the high risk unit. Okay, ataupun prolonged labor, that sort of factors. So the midwives ada criteria who needs to be transferred to the high-risk unit where they need to have full CTG. Okay, so don't confuse. Tadi the soalan, do we continue CTG? Do we continue every 5 minutes? Now that's a bit of a mix-up because this patient memang ada CTG. So we want to continue CTG monitoring until the baby is born. Whatever your decision is, you continue until the baby is born. Okay, does that answer your question? Do you want to move on to the next slide?
Okay, so we'll move on to the second questions. Before that, Dr. Imelda, if you don't mind, can we do the quiz first? Then after that, we will discuss.
We can do it that way.
Yeah. So we will discuss about the what outcome of the baby, and also mungkin CTG prior to the second stage CTG also. Okay, right. Okay, so I pass to Dr. Mumtaz.
Okay, we'll move to the next question. Okay, 37 years old, Gravida 4, para 2+1 at post-date 1 day. Antenatally has 1 previous car, admitted for PROM, 10 hours in labor, OS is only 6 cm, station -1, membrane absent, clear LIQA. So what is your interpretation of this CTG? Okay, so we'll finish the quizzes first. So I'll move on to the next question. A 31-year-old, Gravida 3, para 1+1 at 39 weeks, 5 days POA. Antenatally, the fetus with amniotic band. However, detailed scan structurally normal fetus. Clinically estimated fetal weight around 3 to 3.2. She was sent to labor room with OS 4 cm. ARM was done, showed clear LIQA. 1.5 hour, OS progressed to fully. Assessment at this CTG, OS fully, station +1, LOA, no caput, no molding. So what would you want to do next? Okay. Okay, moving on to the next question. A 23-year-old primary gravida at 38 weeks, 6 days period of amenorrhea with GPS carrier presented in spontaneous labor. Clinically, baby is around 3.2 to 3.4. Assessment at this point of CTG was already 5 cm dilated, cervix 0.5 cm, station -1, ARM was done and showed MMSL. So how would you interpret this CTG? Okay, moving on to the next question. A 24-year-old primary gravida at post-date 8 days, admitted for induction of labor in view of post-date. Estimated fetal weight is around 3.2 to 3.4 kilogram. She was sent to labor room with OS 4 cm. ARM was done and showed light meconium stain LIQA. She was started on pitocin augmentation. So what would you want to do next with this CTG? Okay. Okay, next question. So this CTG is for a 25-year-old primary gravida at date. presented in spontaneous labor. Clinically, baby is around 3.2 to 3.4 kilograms. She was sent to labor room with os 6 centimeter. ARM was done, showed clear LICOA. 3 hours later, progressed to fully. Assessment at this point is station +1 direct OA, caput 2x2 with molding grade 1. So what do you want to do with this kind of CTG? Okay. So the second last question. So this CTG belongs to a 26-year-old primary gravida at 39 weeks. Antenatally, she has maternal underweight with a BMI of 15, presented with PRON. Baby is around 2.8 to 3 kilo. She was sent to labor room with os 6 centimeter dilated, clear LICOA, 4 hours in labor, progress to fully. And at this point, BE, os fully, station +1, ROA, caput 2x2. So what would you want to do? Okay. So last question. A 30-year-old, gravida 3 para 2 at post-date 9 days, admitted for induction of labor for post-date, and she was induced with poly catheter. Baby is around 2.8 to 3 kilo. She was sent to labor room with os 4 centimeter. ARM was done and showed clear LICOA. 4 hours in labor, os only progressed to 5 cm. Cervix was effaced, station -1. LICOA is still clear. So what is your next plan? Okay, so that is the end of our question.
Okay, thank you, Dr. Mumtazah. Right, so I would like to share my slides for our case discussions. So for a while, I will share my screen first. Right, okay. So this is a case, a full case discussion. Just now is only for warming up a little bit in this evening. Okay. So okay, first case. This is a primary gravida at 39 weeks with maternal underweight, was presented with leaking. Clinically about 2.8 to 3 kilos, was sent to labor room with os of 6 centimeter. During that time, membrane is already absent with clear LICOA. So after 4 hours in labor, os is fully. So this is her CTG prior to second stage. As we can see, her CTG prior to second stage is normal. Do you want to comment anything, Dr. Imelda, about this CTG prior to second stage? You agree this is a normal CTG?
Yeah, this is a good CTG, kan? Now, when you have accelerations during labor, you know that this baby does not have problems with hypoxia. So, dia ni ada, semua ni ada each feature that you see ada negative predictive value. CTG ni ada negative predictive value dia. And you see, the thing is that then CTG is meant to be a screening tool, not a diagnostic tool. And we don't actually use CTG to say there is fetal hypoxia because it's a screening tool. Your diagnosis of fetal hypoxia or HIE comes after birth when you look at the cord pH. But because it's a screening tool, bila you tengok, tapi dia very high negative predictive value of close to 100%, then you know when the CTG is normal, this baby is not hypoxic. Alright, especially kalau ada acceleration. Presence of acceleration is not mandatory for a normal CTG in labor, but antenatal CTG lain from intrapartum CTG. Alright, So if you see antenatal CTG tak ada acceleration, I am worried. But kalau intrapartum monitoring, woman is in labor, tak ada acceleration, I'm not bothered because that's not a feature that you must have masa labor. Because baby is more stressed in labor, it's a stress test. Tapi kalau you nampak acceleration in labor, you tahu already. Negative predictive value is so high with a CTG that you know this baby does not have hypoxia. It gives you that reassurance. Okay, even in between deceleration, lepas tu you nampak proper acceleration, you know this baby is playing with you. All right, continue.
So this is her CTG prior to second stage. As you can see, she's actually fully at these times of CTG. During that time, station is +1, caput 2 by 2 with ROA position and clear LIPA. All right, so this is a second stage CTG that we discussed during our quiz. So about 54 of our participants agreed for instrumental delivery at these times of at this time, Dr. Imelda. So what do you have? And also about 29 of our participants is agreed for cesarean sections instead of vacuums, and 6 of them will encourage patient to push, and 2 out of them will wait and see.
Okay, I want you to go back and see how long do you think the CTG has been pathological, before you make a decision for a cesarean section. This is a important decision is when you decide it's pathological first. So it's so easy kan, kita tengok in retrospect, senang saja nak criticize kan. But when you are there, things can be quite different. So what the first thing to know is, if you think the CTG is pathological, at which point it became pathological? Can we go back?
So go back.
The one before this. Okay. So you kata os fully. Just before that, I saying 10 minutes before that, the CTG was normal kan?
So
Yeah, we nampak baseline of about 140. We see normal variability. Contractions are not so frequent. Okay, it doesn't look like tachysystole. But we can see we have accelerations. We don't have any deceleration. So the first 20 minutes of the CTG is entirely normal, right? Do you all agree?
yeah.
Okay. And then things start to change when she is fully, okay? So when she starts fully, and then you saw one deceleration there, and then it picked up to normal, finally got to normal baseline and normal variety. How long was that deceleration for? It's not clear to me. Sebab dia divided into 2, your CTG.
So decelerations is
So satu je kat situ kan?
so betul.
Satu je deceleration kat situ kan? It's only one. So remember what we said about concerning feature, that you want to see 50% or more of the contractions. Deceleration, is it recovering to normal baseline? Is it recovering to normal variability? Is it more than 60 beats per minute drop? And then does it take more than 1 minute to recover? So are we meeting any of those criteria?
Depan dia luas.
I would say
Sing dekat luar.
it lasted for 60 seconds.
Assalamualaikum.
Yeah, but there's only one kan? Ada tak any more deceleration after that?
So this is decelerations.
Satu tu je kan? Is that the same one? Because it looks like the CTG has been cut.
It's same. It's continuation from the previous CTG.
So this is the deceleration of previous CTG. And then dia dah recover, okay? Lepas tu it looks like normal variability, normal baseline, okay? So I think to make a very decision for cesarean section, you kena first dulu kata ini pathological CTG. And as far as I'm concerned, belum lagi meet that criteria. After that, is this delivered already? After the second half tu macam tak ada dah contact.
Okay. So,
Is that time of delivery?
so basically this
AV cup applied. Okay. So What do you think happened? Is that loss of contact or there is no fetal heart rate?
So anyone from the floor? Any suggestions?
That could be bradycardia, kan?
Yeah.
Or, you know, that's the thing. When you have loss of contact, you cannot tell whether the baby is okay or not. You have to deliver. And I don't take chances. Fetal scalp, first of all, if you have fetal scalp sampling, all right, first of all, you much better to have fetal scalp electrode, kan? Some units ada fetal scalp electrode. So you can monitor if you have loss of contact abdominally, then you apply the fetal scalp electrode to see if you are getting heart rate. Now, someone asked a question about fetal blood sampling. Fetal blood sampling pun ada kriteria dia. Okay, number one, kalau fully dilated, kita tak nak buat fetal blood sampling dah, because you can deliver already. Unless the head is still very high and it's not enough time for you to nak buat instrumental delivery. Because remember, second stage, you can allow 1 hour for head descent in someone without epidural before you start active pushing. So if the head is still high in a second stage, right, and the CTG is normal, you can allow an hour for head to descend before you encourage active pushing. Even if kalau CTG yang normal, you can give a little bit more time pun tak apa, as long as you're seeing progress. Jangan dia tak ada progress langsung and then you tunggu lama-lama. But if someone has epidural, the passive second stage, we allow up to 2 hours for head to descend before you ask woman to start pushing, all right? So at this time, kalau CTG becomes pathological, tapi you cannot do instrumental delivery yet because the head is just coming down but not quite coming down, all right? You can do the option of doing a fetal blood sampling, but there are criteria for that. Number one is there is no infectious blood-borne disorder macam, you know, mama ada HIV ke, tak ada hepatitis B antigen positive where you can have more transmission of infection to the baby. Secondly, you have ruled out baby yang could possibly come from an ITP mother, kan? Kalau if a mother has ITP, there's a 1% chance that the baby could also have low platelet count, especially kalau ada antibodies, maternal antibodies. So these ones you tak nak buat fetal blood sampling. Third one, kalau dia ada failure to progress, there's no point lah. Yang tu kena Caesar. The head is so high and it's been high for ages and isn't coming down, alright, with pushing. So, you know, this one kena dah failure to progress dah, buat apa nak buat fetal blood sampling, alright? So, and then fourth, tak ada bradycardia. Bradycardia is not the time to do fetal blood sampling. So in this aspect, CTG ni, there poor contact, kita tak tahu baby is okay or not. So this is not a scenario where kita nak buat fetal blood sampling. Okay, fetal blood sampling is for pathological CTG, not for bradycardic baby. Okay, but in this scenario where you tak tahu pathological or bradycardia, you got to assume this is bradycardia. Kalau tak tahu, you got to err on the side of safety. So I wouldn't want to do fetal blood sampling kalau tak ada fetal heart rate. Okay, so so therefore, in this scenario, the answer is no. I will not do fetal blood sampling. Kalau ada fetal scalp electrode, I want to put it on. All right, but the decision to put the kiwi cup is not a bad decision. This is a good decision because you tak tahu what the baby is doing. You want to get the baby out. So the first 20 minutes of the CTG on here does not show enough for me to say pathological, but suddenly something has happened, right? Something can happen quite quickly. It's usually something happen yang very quick ni, kadang-kadang ada cord accident, kadang-kadang ada baby yang memang dah ada IUGR and already have placental insufficiency. So sometimes you get a sudden change and you got to act on it.
Okay.
Does that answer the questions?
Yeah, I think it's well answered. Okay, so somehow baby was delivered via vacuum assisted delivery with fresh meconium, but unfortunately baby was born not vigorous with coronal neck times 2 tights and with code pH with evidence of acidosis.
Yeah. See, the thing is, when you look back, it's very easy for you to criticize and say should have done an emergency Caesar because you look at the cord pH 7.0, kan? Baby born not in good condition. But then when would you make that decision to do a cesarean section? At the point when you lost the heart rate, kan? Dia deliver within 10 minutes saja. That's not enough. If you make a plan, let's do cesarean section, you will the patient to OT, it's going to take more than 10 minutes to get this baby out that way. So the decision to actually apply a kiwi cup and deliver quickly, it's good decision because you actually got the baby out quickly, quicker than you would have got it baby out by cesarean section, kan? And that's why you need to know at which point is the CTG pathological for you to make a decision. And when you know when the CTG has been pathological, you can then decide, nak criticize, kenapa tak buat Caesar. But I don't see any point where this is a wrong management. This is Kiwi Cup is absolutely good enough management because they did get the baby out, kan? And it's very quick from the time the CTG shows pathological pattern that is just before the halfway tu.
Yeah, true. So
Yeah.
well done for those who are manage these questions. So the decision is actually good decisions. All right, so we move on to second case. So this case actually not in our quiz. So she is primate gravida at 38 weeks plus 6 days. Antenatally was uneventful. She was presented with leaking liqua with clinically baby about 3.2 to 3.4 kilogram. So she was sent to labor room with os of 6 centimeter and ARM was done with clear liqua. So 5 hours in labor, os is fully. So this is her CTG during second stage. So do you like to comment anything, Dr. Imelda?
Alamak, cord pH dia 6.88. Kesian baby ni, kan? Apgar score is 1, 4 and 4, is that right? So we want again to look at which point do you think it is pathological for you to start intervention? Okay. Yeah, this is the CTG before this, tak nampak? This the one before this.
Tak dapat nak trace.
So she was fully dilated at that point tu masa depa buat VE.
Yeah.
So it looks like the first 10 minutes of CTG variability tu I worry. Nampak tak variability dia?
So this one is it?
Yes, kan?
Yeah, okay.
Baseline nampak okay, tapi this is why you need to know before that. You see, the thing about CTGs is, kalau dah ada pathological CTG and you don't act on it, kadang-kadang poor variability. How long is poor variability for you to say it's pathological or an abnormal feature? Can somebody volunteer?
Any volunteer?
50 minutes. Well done.
Dan Dr. Azhar.
Azhar Syahri Azizan, you're a star. So 50 minutes. Kalau kan, this is the normal scenario when you find a baby is so acidotic at birth that the CTG has been going on and then you tengok variability poor and then after that, oh ada sikit improvement for about a minute or two and then goes back to poor variability. Saat ni buat VE ada sikit and then goes back to poor variability and it goes on for a longer stretch. It's actually pathological CTG. So baby ni when it's already poorly, bila ada insult cepat saja dia deteriorate. So that is why you got to look at the CTG before this. I suspect for a baby to get to cord pH 6.88, the insult has been going on for a while. Okay, So even before they're fully dilated tu, tengok kat belakang tu, variability tu does not look like it is a normal variability. There's something going on there. Okay, and then after that you are getting baby yang dah over the compensation, dia come to the limit. Bila they come to the limit, suddenly you get loss of context, probably bradycardic already. And then picking up maternal heart rate. Kan, we cannot assess that CTG. There is no normal fetal heart rate there at all. For how long? 10 minutes, 20 minutes. And then maternal cup applied about 25 minutes after the os is fully.
Yeah.
All right. That was a good decision, because if you only saw the CTG at that point, what else can you do, kan? Because kalau the head is so deliverable and so easy to deliver at that stage, you do the best you can. You can use metal cup. You don't necessarily have to do a cesarean section.
True.
Okay, sama Muhammad Farhan kata, if I'm not mistaken, Nice says presence of acceleration when there is poor variability. Apa dia? What's the next sentence? It is means what?
This is a sign that the baby is doing well. So it means that
Okay, now you cannot have acceleration in when there's poor variability. The answer is no. Poor variability is a pretty bad abnormal feature. There is no such thing as acceleration when there's poor variability. So I've never seen baby with bad outcome have acceleration. That's number one. And I've never seen any babies with poor variability have acceleration. So what happened is that is not an acceleration. Okay, it could be a reflex tachycardia or fetal heart rate baseline has gone up. So can you see that at 15 minutes into the trace, there is what looks like fetal heart rate baseline has gone up, lepas tu deceleration, and then goes back up to baseline that is a bit high, lepas tu we lost it. So I will not agree that that is an acceleration kalau ada poor variability. For the same reason, you can have shallow deceleration with poor variability, but you cannot have shallow deceleration when normal variability. Shallow deceleration is only something you can say in when the variability is poor. So no, this is not an acceleration.
okay, right. Okay, can we move on to the next case? Okay, the case. So case number 3, patient of 42 years old, primary gravida at 38 weeks plus 5 days. She had primary subfertility for 6 years and this is a spontaneous conceptions. So she's actually presented with spontaneous labor with os of 7 centimeter. And after 2 hours in labor room, she had SROM with clear liqua and entered to second stage. So this is her CTG during second stage. So as you can see, the os is fully here. Then this is patient was decided for emergency cesarean section at this time of point, and baby was delivered via catheter with Apgar score of 3 and was 3 at 1 minute and 3T at 5 minutes with code pH of 6.99. Do you want to comment anything, Prof? Doctor? Sorry.
What was the reason for cesarean section?
Okay,
I'm not.
because of during this time, the assessment it shows that big caput about 5 times 5 centimeter, which is not suitable for instrumental delivery.
Yeah. So basically the baby's head is higher. That's why there is a big caput. So that is your decision has to be made clinical judgment examination, not by CTG. So the CTG punya assessment only tells you, yep, I got to deliver or not, right? Is this pathological or not? If it's pathological, I want to deliver. And then you use your clinical skills to decide mode of delivery. Okay, CTG does not tell you the mode of delivery. CTG tells you you got to deliver or not, whether it's pathological or not. So then your decision tu, there's no right or wrong, kan? Because of course, if it's not fully dilated, you have to deliver, you do a cesarean section. If it's fully dilated, you got to assess, you got to do a bimanual palpation. Is it cephalic, how much palpation per abdomen? Because sometimes it's all caput coming down below. And then actually 3/5 per abdomen, yang banyak yang you feel station +1 is just the caput. All right, sometimes it's a deflex OP with a lot of caput and no descent with maternal pushing. So, you know, you have your decision is based on your clinical judgment. So yang tu kita tak boleh nak, you know, criticize, but you can look at the CTG and say whether or not it's pathological enough for you to intervene. Okay. So based on your CTG, sekarang you can see, is there any trace before this?
No trace.
No.
This is
All right. So here you see a baseline of 150 beats per minute. Okay. And that is the baseline rising or not. You can see the baseline rising. So bila they decide for cesarean section, nampak tak baseline tu is higher than the startnya baseline. Okay, so that one is already above 160, kan? So baseline alone, if you look at NICE guideline, you have what is normal, what is considered kind of worrying, and what is the abnormal feature. So baseline more than 160, that one is one area when if you have more than 180, kita kata abnormal, kan? So this is above 160, but you see that rising in baseline. Then you look at that variability. I'm not happy with the variability, are you? Variability, so even from the first 20 minutes into the trace, you nampak ada deceleration. That is recovering to poor variability, nampak tak? There, poor variability there. That's already a concerning feature with that deceleration. And then you nampak the baseline continuing to rise. So I do agree that this is become a pathological CTG. Tapi before that, kita nak tengok, was it already pathological before that? Okay. And then decision made for cesarean section, kalau tak boleh buat vaginal birth, that is a correct decision because it's already pathological CTG.
All right. Okay, so there's a question here. How was the baby at birth? Any syndromic features? Okay, so basically this baby is actually had AVM. AV malformations after we do the MRI for this baby. Okay. So but no syndromic features. Right, so we move on to the next case. Okay, case number 4. So 28 years old, primary gravida at 39 weeks 6 days. So she was admitted with leaking liquor, and was sent to and in what the labor was progressed to 8 centimeter, and after 1 hour in labor room, she's entered to 2nd stage. So this is her CTG prior to 2nd stage. I think this is the one yang kita discuss just now, kan? What is the CTG prior to this types of CTG? Just now yang Dr Imelda tanya how the CTG prior to the 2nd stage. So this is a CTG prior to 2nd stage lah. As we can see, the baseline is actually 130. Yeah. Okay. And most of our participant agreed to do vacuum assisted delivery, about 100 ones of the participants.
Okay, tadi ada question. What if baseline drop from 140 to 120? Sorry, I missed that question tadi. Siapa tanya question?
Doctor just now mentioned about changing in baseline fetal heart rate. If the fetal heart rate is dropped from 140 to 120 beats and plateauing, any comments on this? So previously,
Which one? Which part was it that it dropped 140 to 120? Mana tadi yang which CTG?
Ingat Mak Leha dia lagi dulu.
Dia tu daripada mana? Memang staff kita ke apa dia tu? Mana?
So tunjuk Sat dekat mana yang soalan tu, which CTG trace, kat mana yang drop tu?
Dia sister kan, dia boleh.
Siapa In? The, just a question, not based on the CTG. So the question is,
Just a question that you kena tengok the CTG in context. Kita kena tengok overall kan. So when you do Dr. C Bravado, the overall picture tu kena tengok, bukan satu je baseline tu. So we cannot say normal, suspicious or pathological with just one feature.
okay. All right. So for this case, it's actually baby was delivered via vacuum assisted delivery lah. At this at this time we have applied a kiwi cup. So baby was born alhamdulillah vigorous with no evidence of acidosis. However, baby was admitted to SN for TTN. Okay, I think this case is already discussed during our quiz just now.
Yeah.
Yeah. So we move on to next case, case number 5. Patient 24 years old, primary gravida at post date plus 8 days. Antenatal was uneventful and she was induced with prostatic aneurysmal. So she was sent to labor room as Bishop score favorable with ulcers 4 cm and ARM was done with LMSL and she was started with Pitocin augmentations for expedited delivery. So this is the quiz just now that we have asked the participants. So this is a CTG after we start Pitocins and 90% of participants agreed to off the IV Pitocins. Okay, doctor. So what do you think about the practice of withhold of the Pitocin if CTG is looked suspicious of abnormal?
Okay. Now, bila kita tengok the CTG kan, kita tengok buat Dr. C Bravado kan. And you can see, look at the contractions. That's why Dr. C Bravado is so important because don't miss out C. Now, can you see how many contractions there are?
So there is about 5 contractions.
Yeah, that is more frequent than we want, kan? Kita nak bagi baby, when we look at research in this area that has been done on why we make the CTG punya guidelines the way it is that you want to give time for rest in between contractions. Now, what you all need to know is that during contraction, uterine perfusion is reduced by 70%. So when you have a contraction for 1 minute, it is in a normal labor, uterine perfusion reduced by 70%. So I want you to imagine yourself as the baby, kalau kita the baby and we are swimming in the ocean, all right? When a contraction comes, it's the same as having a big ombak datang. Okay, ombak datang for 1 minute contraction over our head and we go underneath and we hold our breath for 1 minute, tunggu ombak tu pass, right? Then we resurface and we breathe. Okay, now placental perfusion is restored in between contraction and we breathe and we are okay. Now the fetus at term, a normal size baby yang memang tak ada placental insufficiency can withhold 12 hours of labor no problem because they've got the fetal hemoglobin, right? And if your contractions is going like 3 times in 10 minutes, 4 times in 10 minutes, is no big deal. You resurface and you breathe. Now, if you have a contractions macam ni, you start someone on syntocinon. The idea of starting it slowly, kan? You start at the minimum amount, like 3 mils per hour. You follow your protocol. And then after some protocols, say after 30 minutes, you increase to 6 mils per hour, increase to 12. That idea of titration is to see how much contractions, because some moms will respond very quickly. And you have very good, strong contractions, then you palpate it and you see, look at the CTG. And some mothers, right, don't respond enough. You have to keep increasing the syntocinon until it is, even up to maximum limit. Now, what happened is the mom who is multi-gravid, they usually respond quite quickly and easily. And then when you see a CTG like this, the first thing you need to do is not just to stop the hyperstimulation, because you can see this one is tachysystole with abnormal CTG. So if the CTG changes to either suspicious or pathological in response to tachysystole, then we call this hyperstimulation. The other thing that can happen is, can you see the middle of the CTG too? Right up to, what is it? Dekat number 25 minutes into the trace. Can you see that contraction is like 3 minutes long? That contraction, yeah. Now that is a hypertonus uterus. Now, hypertonus pun kita tak mau. Hypertonus is 2 minutes or more. Contraction tak berhenti, right? So that is also considered hyperstimulation. So hyperstimulation occurs when there is tachysystole. Tachysystole means there's less than 1 minute break between contractions. Okay. Second, if there is hypertonus contraction with CTG change, either suspicious or pathological, we class them as hyperstimulation. Now, if you see this, right, the first thing to do is to stop the syntocinon, put the mom in left lateral position and start IV hydration. Okay, because it has been proven that left lateral position improve blood flow uterine perfusion. Okay, and IV hydration helps to improve the amniotic fluid. Dia cepat increase balik amniotic fluid in the uterine cavity. So kalau ada cord compression associated with uterine contractions, you can help to relieve that a little bit more when you have a lot of IV hydration, amniotic fluid is restored and cord compression is reduced. So then you can decide, okay, stop synto, put left lateral position, IV hydration. Kalau this is a response to prostin, you want to add the butylene as well, because prostin tu dia tak, you cannot stop the contractions like you can with syntocinon. And so if you don't see any improvement, so after that contractions seem to have stopped. Is that because pitocin has been stopped? So at 5:10 and 5:15, you don't seem to see any more contraction. I assume pitocin's been stopped. Yeah? Tapi kalau you tak tengok recovery in the fetal heart rate, then you should do a cesarean section, because I don't see a recovery in fetal heart rate. Here you can see baseline dia normal, tapi variability is like shit. Right? And this is when you see shallow decelerations. So when you have variability less than 5 beats per minute, then even decelerations of less than 15 beats per minute is considered deceleration. So a normal variability pattern, you need to see deceleration, the definition has to be 15 beats per minute below baseline, kan? But kalau the variability is poor, even a little bit, you nampak beralun-alun sikit tu, then tu dah deceleration. So now we have deceleration returning to poor variability. Now this is very worrying. I worry about this even more.
Okay, all right.
Yeah. So what happened to her after that?
After that, we have stopped her pitocin and actually back to normal.
Ah, very good. So as soon as you stop pitocin, they recover.
Yeah.
Is that right? Yeah, well done.
So the questions here, Prof, if for example, for this question is actually the CTG is actually coming back to normal. So and this contraction is actually suboptimal. So what is the appropriate titration should we start for this patient? For example,
dia macam ni. This patient is not a primary gravida.
Yeah.
Kan? Dia berapa? Gravida berapa? Para berapa? I forgot the story. Parity wise?
is primary gravida at post-date plus 8 days.
Primary gravida.
Primary gravida.
Oh, okay, fine. Okay, so now what we want to do, That was a question tadi. How long do we wait? Is it after you stop Pitocin? Correct?
So,
Yeah. So I tengok kedai CTG tu, bila you stop Pitocin, you put in left lateral position, and you start IV hydration. Okay. The other thing you have to do is do a VE to make sure tak ada cord prolapse kan. That is very important. You cannot rule that out. Make sure there is no abruption or chorioamnionitis feature. You gotta exclude all the things which makes you to make you decide that you can continue to have a normal birth. Correct or not? Yeah? When you exclude all that, by the time you put the patient in left lateral and IV hydration, you nak tengok Pitocin tu contraction tu stop ke tidak. Because sometimes Pitocin tu walaupun you stop, contraction dia continue to be hyperstimulation pattern, tachysystole or hypertonus. That's when you need to get your terbutaline. Okay, so the first thing you want to do is, have you acted on the CTG? So acting on a CTG tu not necessarily delivery. So bila you write your documentation, kata medical legally, mereka nak tengok, have you noticed that CTG is pathological? When did you realize CTG pathological? Tak realize is a problem. Okay. Secondly, bila you dah realize, have you taken action? Tak take action, that's a problem. Okay. But taking action does not mean delivery. Taking action is stop Pitocin, left lateral position, IV hydration, call your specialist, do your VE, right? And then by that time, a few minutes have gone. And you can decide if Pitocin is working, has stopped, the contraction dah stop. Is there any recovery in the CTG once the contraction stopped? Kalau contraction tak stop juga, then you want to do your terbutaline. Get it back to baby having to recover at least 1 minute in between contraction. You want that recovery back for the baby. Okay, because even in a term baby who is strong, tak ada IUGR, you know, you push that baby underwater for so long, that is going to be a problem. So you got to think yourself like the baby. Okay, how much can you put up with that? So once they dah recover, they dah okay. What is my view on minyak susu? Hang ni tukar cerita, kita tak habis lagi cerita. Nanti Sat, kita nak habis this part. Air selusur tu depending on, you see I lost my train of thought already. Okay, air selusur tu depends on what's in it. Okay, so kalau the patient kata dia ada air selusur, you got to tanya, apa dalam air selusur ni? Because some people, dia kata air selusur tu air jampi saja. Tak ada benda lain kat dalam tu. Dia baca Quran, siapa baca Yasin, dia bagi air tu untuk dia minum. I tak ada any problem with that. Right? Don't say tak boleh. Sometimes mereka bawa air zam-zam. Mereka panggil air susu pasal dia baca-baca. Bukan pasal mereka letak any, akar kacil Fatimah ke apa kan. Some people, when they say air selusuh tu, dia buat daripada rendaman akar Fatimah or something like that, which have some sort of possible stimulative properties. Nak bagi cepat kesalin. Yang tu is very dangerous. So this is not something that just happened in Malaysia. You find that in traditional practice in other countries as well, in Africa, in India, mereka ada mereka punya air selusuh. Dia bagi nama lain lah. But they have their own herbs and roots, which properties which is known to cause contractions like ergots. You know, ergots are really bad. Ergometrin, you don't want to give in labor because you will have hypertonus uterus. And that is increase the risk of fetal death, abnormal pathological CTG, even uterine rupture has been reported in Africa, where they use this, mereka punya air selusuh, mereka campur dengan elephant dung pun ada. And it has been shown that in some studies that these have caused more fetal death, more cesarean sections, and uterine ruptures in mother. So definitely no for air selusuh if they put anything in it. But if they say hanya air zam-zam, air bacaan Yasin, Quran, whatever it is, then let them have it.
Right. So, so 7 hours in os was remain 4 centimeter with light meconium stain lipo, and this is a CTG during
This same patient lah.
patient.
Tadi dah recover dah kan?
Yes. Yang ni after 7 hours, doktor.
Tadi ada seorang lagi tanya soalan. Berapa lama before you restart pitocin? Is that right?
So, how long?
Tadi ada soalan tu, we missed that part. So it depends on kalau the contractions is good enough for a mom to progress. Okay. Induction of labor ni macam nak start engine kereta tau. Kan? Setengah orang kita nak start tu punyalah lama kita kena tolak kereta dia. Right? Bila dia dah start, okay, they go on their own momentum. And sometimes you can stop the syntocinon halfway bila dah labor dah established, especially in multi-gravids, right? Women yang dah bersalin a few times ni, mereka punya syntocinon ni, once the labor is established, actually the kereta you dah tolak dia rolling down the hill dah. So once they turn down the hill, you stop pushing, alright? You can just stop the syntocinon and let it continue at its own steam, right? Primary gravida kadang-kadang kita kena push lama sikit. It's like you pushing a car on a flat surface, but multi-gravids, you are pushing the kereta down a hill, alright? So when the mother's punya contractions take on its own accord, you dah tengok dah hyperstimulation, you stop the pitocin, and then tengok contraction dia restart on its own, then they make their own progress, tak payah pun start syntocinon again. Just the aim is to progress in labor. Okay, the aim is not fast labors. It's a safe delivery and healthy mom and baby.
Okay, all right. Right, so this is a CTG after 7 hours. So we have proceed her with cesarean section for pathological CTG based on the CTG. So in Liqua is stick meconium stain Liqua and Abgas is 6 at 1 minute stand at 5 minutes, but there's no evidence of acidosis from cord.
Okay. Can I ask you to continue for a minute? Let me answer this call. Just 1 minute, you continue, yeah?
Okay, all right, all right. All right. Okay, all right. So this is the outcome of the baby. Okay, so there is a question from Farhan. However, we will wait for Dr. Imelda first. All right. So the next case, case number 6. So 23 years old, primary gravida at 38 weeks plus 6 days. So antenatally, she's have a GBS carrier, was presented to us with spontaneous labor. So abdominal examination shows of the baby about 3.2 to 3.4 kilogram, and the VE done shows that OS is 5 centimeter, ARM done is MMSL. So this is her CTG during the OS 5 centimeter with cervix of 0.5 and session -1 and MMSL. So based on the CTG, the interpretation from most of our participants is actually suspicious. About 33 of our participants said it is pathological. 9 of our participants said is normal.
Okay. Now, I agree with all of you. Sebab you kena tengok the CTG at one point. The first half of CTG is fantastic, kan? The first 20 minutes is completely normal, right? And then the start of these decelerations that you see, the first 10 minutes tak boleh kata pathological lagi, kan? Because baru saja. So you want to see 50%, more than 50% of per contractions ada deceleration. So kena tengok dulu kan. And then for 30 minutes, isn't it? According to NICE guideline. So actually dia baru saja bila the first 10 minutes of that decelerations, that one is at that point kita kata suspicious because there's not enough time for you to say it's already pathological yet. So, but my worry is the baseline variability, kan? Is it 5 beats? Just about 5 beats, kan? Baseline variability just about 5 beats is still alright, kan? And then you see the decelerations recovery. Well, they are mainly less than 60 seconds to recover and less than 60 beats drop.
Right.
So, and also dia punya baseline rate is maintained. Variability to just above 5 beats. So it's still alright, isn't it?
Yeah, true.
So yeah, it's still alright. So I've not seen enough. So we now got into 30 minutes of that trace with decelerations. I've not seen enough for me to say it's pathological yet, but it's probably going to become pathological, kan? You have to be on guard. When you see this is suspicious, all right, you got to be really on guard now because anytime it can become pathological. So far, belum lagi enough criteria to say pathological, but kalau variability to reduce a bit further, less than 5 beats, I dah kata pathological lah.
Okay. So, all right. Sorry. Okay. So after 1.5 hours later, she went to second stage. So she successfully delivered via spontaneous vertex delivery, which second stage lasted about 11 minutes. But for pH shows of evidence of acidosis with VPG of 7.16, and baby was admitted to NICU for MAS. From your opinion, Prof, is it worth to wait for spontaneous vertex delivery, or should we intervene earlier for this patient?
This is after 1.5 hours, but what was the variability? Did it continue to be more than 5 or not?
Prior to that, the CTG is actually normal. The variability is 5.
Variability that improve.
Yeah, true.
But, okay. And then look at the contractions. Can I just get a recap? Was there syntocinon involved? Because contractions they're quite frequent, no?
No, this is spontaneous. So she
Spontaneous. Okay. So then we look at the baseline heart rate of 140, and here variability I nampak flat sikit, kan? At the start of the variability dia flat sikit. So ada decelerations recovering to poor variability. So that's you're starting to get concerned because of that. Kalau yang tu continue for about 30 minutes, kita kata pathological. But so that has, as I think, looks like it's been going on before that, the trace, pathological trace. Sometimes you got to actually look back because from the start of this trace, I don't see it as normal. Sebab of the poor variability.
So actually at the below one of the CTG ni,
Oh, you dah nampak ni. You tengok dari bawah.
dia ada daripada 2 PM lah. So because of baby.
So actually kan, oh, this is the start of the, okay, looking from below, yeah, you can see it's a flat trace even before this batch of CTG kan. Flat trace kan, going on for a while. And then ada shallow deceleration. So yang tu dah pathological dah.
So this is a pathological.
Masa mula tu bila kita tengok suspicious, I was a bit worried because variability is just above 5. Itu anytime can become pathological. And it did because it became flat.
Okay.
Yeah. So you want to actually have intervention a bit earlier for poor variability.
I see. All right. Okay.
There's something about variability that I worry more than just decelerations. Sometimes you can have poor variability only and there's no decelerations. I worry that because that's the reason why 50 minutes is already pathological. You have to intervene, make a decision for delivery because, you know, that variability ni, poor variability can be worse than, you know, just decelerations without concerning feature.
Okay. All right. So there is a question from Farhan, Dr. Imelda. Some clinician would the CTG to be normal before offering opioids such as tramadol or petidine. Is this a correct practice? From Farhan.
I cannot hear the question. Apa dia? Some
Clinician would wait the CTG to be normal before offering opiates, such as tramadol and petidine. Is this a correct practice?
okay. Petidine ni kita nak bagi for pain relief. Okay. It's the pain relief for the mother. Kan? So your CTG does not make a decision whether or not you want to offer mother pain relief or not. CTG tells us whether it's normal. That's why kita kena systematic. Is it normal? Is it suspicious? Is it pathological? Pathological, you kena take action, and the action is definitely not petidine. Right? So
teruk lagi kat mata Mariam tu.
So you, okay. What is my opinion about poor variability that respond to scalp stimulation? You know, we had a case like this before of a mother. This was when I was in London. Dia ada poor variability and then dia panggil doktor. Doktor datang buat ada scalp stimulation. Lepas tu dia tinggal. Saat ni poor variability balik. Lagi setengah jam, 1 hour. Mai balik buat VE scalp stimulation. Okay, tinggal. Saat ni mai balik. Poor variability balik. Buat scalp stimulation. You know that baby had a cord pH of 6.9. Because eventually you biar lama-lama suddenly jadi bradycardia. Right? So, you cannot look at a scalp stimulation alone. You want to look what happened after that, the overall pattern after that. Okay, and if it's only scalp stimulation they improve and then after that back to poor variability, there is something not right. Kalau after that they improve and stays normal, then that's okay. What was that question tadi? I missed.
So scalp stimulation.
There was another question after that, just popped up.
If patient's CTG improve in between with good acceleration and bit to bit, then recurrent poor variability afterwards, should we keep the 50 minutes threshold to decide?
Yes, yeah. So bila dah normal tu normal lah kan. Lepas tu your threshold will be after that there's a change of CTG. You're gonna again tengok is this normal, suspicious or pathological.
All right. Okay. All right. So actually we have totals of 13 cases to be discussed, but currently we already at 4:30 p.m. Do you mind to continue, Dr.
I
Imelda?
got you. Let me just answer this one more phone call and I'll be back.
Okay. All right. Okay. All right. So we have case number 7. So 31 years old, primary gravida at 38 weeks. So antenatally, she's have GDM on metformin 1 gram BD, and she had been admitted for IOL and induced with Foley. So clinically, baby is about 2.6 to 2.8 kilogram. She was sent to labor room with os of 6 centimeter with clear liqua. 3.5 hour later, os was fully. So this is her CTG during this is at 8 centimeters, and this is during second stage CTG. Okay, so this case is actually not discussed during the quiz lah. So what happened to this patient is actually at this times of point she had episodes of bradycardia for 3 minutes down to 60 beats per minute with the baseline heart rates of 130 beats per minute. And subsequently, os during that time is 8 centimeter with clear liqua and pitocin was withhold during that time. As we can see, the contraction is actually, I would say, is 3 to 4 intense. So, after 1 hour later, she had another episodes of deceleration, bradycardia, about 3 minutes down to 80 beats per minute. And she was decided for vacuum assisted delivery. So this baby was delivered via vacuum assisted delivery with good Apgar score. However, co-PH, there's no evidence of acidosis, but mother is sustained 3B perineal tear. That's Dr. Imelda is Dr. Imelda.
Okay. Now, remember when I said CTG is a screening tool. Okay. When the CTG is pathological, okay, the positive predictive value, ability to pick up, to actually predict hypoxia is not so good. At best, 60%. Okay. When the CTG is normal, the negative predictive value is more than 90%, which means you can be confident. You can be confident when a CTG is normal that this baby does not have hypoxia. Tapi when a CTG is pathological, you cannot say for 100% a baby has hypoxia, tapi you have to take action. But you have to take action because you cannot predict your outcome. If you don't take action and something happens, then you have to answer. So sometimes we have really lousy looking CTG tapi with baby born in good condition. Nasib baik, lega, you've done a good job because it could have been worse if you had left it, right? But you've done a good job. So this is one example where kita nampak CTG ni, I would say yes, you have to take action. It does look pathological. From os 8 centimeters is a big abnormal feature with a deceleration lasting more than 3 minutes kan. Yang tu satu abnormal feature je dah kata pathological. Right? And then after that, you tengok baseline recovery to normal baseline, but variability looks poor. To me, eyeballing it from 4 looks like less than 5 beats per minute, right? So bila you tengok this big deceleration that takes more than 3 minutes to recover, lepas tu poor variability, yang ni ada kata okay, dah pathological, let's plan delivery. And then we'll start moving the mother to OT because this is a pathological CTG, you tak boleh deliver by instrumental delivery. But bila dah masuk OT, give it a chance, do a VE, mana tahu dah fully. Okay, kalau dah fully and you think you can do it instrumental delivery, at that point, just do it. So the crucial thing is not wasting time. Because even dia kata para 3 pun sometimes they don't get to fully that quickly, but you making the preparation and then you kata if you get to full dilatation when we are in OT, we will try and see we can deliver vaginally. Okay, but if it takes longer, then you have not wasted any time. So I think, it's a good decision to intervene when you see pathological CTG. But if the baby comes out good, well done, all right? Because CTG is not a diagnostic tool. This is when fetal blood sampling can come into play, kan? Kan yang ni lah kita kata dia tak ada bleeding to suggest abruption, dia tak ada bradycardia, dia tak ada poor progress in labor, tak ada failure progress. Dia tak ada infection like HIV or hepatitis B, hepatitis C. And then dia tak ada blood disorders. These are the 5 things, criteria, contraindication to fetal blood sampling. Tak ada tu semua. Then sometimes bila tengok macam ni, you nak avoid cesarean section. Okay, then you boleh buat fetal blood sampling and then you get your pH of more than 7.25, then you boleh tunggu sikit in time for full dilatation, right? You give an hour. Kalau kalau the sample shows pH of 7.25 or less, you got to repeat in 30 minutes. So some people get to fully quite quickly. You're just buying time. Still okay, another hour, and then you can do your instrumental delivery once she gets to full dilatation.
Okay, right. Okay, so next scenario. So 25 years old primary Gavrida at date, which is presented with spontaneous labor and sent to labor room with os of 6 centimeter. So 3 hours later, she was entered to second stage. So this is her CTG during second stage. So from the poll just now, most of our participants agree for emergency LSAS, about 43%. About 43 participants. 29 participants will do vacuum assisted delivery for these patients. 15 will be encourage patient to bear down, and one will continue CTG monitoring. So any comment, Dr. Imelda?
Can you tell me the history again? I punya define risk blur sikit tadi. Okay.
An event with spontaneous labor. So she is primary gravida.
So at this point, 6 centimeters.
Yeah.
Or she got to fully.
Yeah, 3 hours.
Okay.
Fully. So this
Okay. So here you are asking me the wrong question. You're asking me mode of delivery based on CTG. That is the wrong question. You want to ask me, is this normal, suspicious, pathological, and do we need intervention for delivery or not? So the answer should be, yes, we need to deliver or not based on CTG. Mode of delivery is based on clinical judgment, not on CTG. So kalau dia dah fully dilated at that point, and the station is by manual palpation, and station is shows that it's favorable for a instrumental delivery, then go for it. Why do you want to do cesarean section, kan? Kalau it's not favorable for instrumental delivery, go ahead for cesarean section, because this one everybody agrees pathological. But what you cannot ask me from this trace is whether should I do emergency Caesar or instrumental delivery.
right. So this patient actually is full here. So during that time, his station is +1 with direct OA positions with caput 2x2 with molding grade 1. So she was decided for vacuum assisted delivery at this point of time. This was delivered by a spontaneous vertex delivery while preparing for vacuum assisted delivery. Cord round neck ×2 with good UPGAR score, and baby was dispatched to mother.
Okay. You tahu tak, cord around the neck ni, semua babies yang born well with normal CTGs and vigorous, good UPGAR scores, have no problems pun ada cord around the neck. That is not something I would report to be anything to act on. So macam, you know, when you write down cord around neck ×2 after birth, as if that's important. Because, you know, how many babies you deliver with very good outcomes of cord around the neck? The answer is many, but nobody mentions it because the baby's fine. As soon as the baby's born, macerated stillbirth lah, apa-apa semua nak mention ada cord around the neck. Right? This is the reason why I have some patients coming to me tengah scan, oh ada cord around neck, tak takut. I said, why you want to look for cord around neck masa scan? There's never a feature, you know, and any part of obstetric ultrasound training, even at subspecialist fetal medicine level, where we need to look for cord around neck when we do detail scan or even growth scan, because that does not change the management of labor and delivery for as long as CTG is normal. Kan?
Yeah.
So, correct. Tapi the problem is when the baby comes out macerated stillbirth and it's an unexplained stillbirth, mesti ada orang mention, tengok ada cord around neck. Saat ni the next pregnancy takut ada cord around neck je nak Caesar. Kan?
Okay, so there is a question from Huawei. Any role of ultrasound in second stage?
Yeah, you can. Okay, so that depends lah. Kalau some patients, you when you do your examination kan, sometimes I do ultrasound. Kalau mother is so obese kan, you nak buat by manual palpation. Sometimes you want to look at the presentation, but not always. Most of the time, I don't use ultrasound in second stage because, you know, you can make assessment on position, presentation by vaginal examination. So, in terms of management, how does an ultrasound scan in the second stage help you? Very little, actually. Twins, yes, definitely. for twins, but not very much. We are now moving forward towards using transvaginal scan for diagnosis of threatened preterm labor. I use the transvaginal scan a lot for cervical length assessment for threatened preterm labor. And some women who have macam what we call vaginismus and cannot tolerate VE at all, okay? Because VE too, you need to feel the cervix, you will go quite far in to feel the cervix. But a translabial ultrasound scan are now being used. You are able to make decisions on that because you can see the cervix still long and effaced or not, and bulging membranes dilated, dilatation in certain patients yang ada vaginismus tak boleh tolerate VE, and you need to know what's going on. You can do translabial ultrasound, even transvaginal sikit dia masuk, dia tak perlu masuk banyak, you can see a lot already. So that is one other area that I use it.
Alright. Okay. So should we move on to next case, Doctor? So the next case, 31 years old, G3 para 1+1 at 39 weeks plus 5 days. So antenatally fetus with amniotic band. However, detailed scan was done, structurally normal fetus. So she was admitted for latent phase of labor. So was sent to labor room for prolonged latent phase with odds of 4 cm and ARM was done with clear liqua. About 1.5 hours later in labor, she was progressed to fully. So from the So from the with this CTG, with also fully, most of our participant said will allow passive second stage. 20 out of 200 is will encourage patient to bear down. So 2 out of 200 will do the admississor and 3 will do instrumental delivery. So this is a second stage CTG. So as we can see, during OS fully, station is +1, LOA position, clear liqua, and also she was delivered via vacuum assisted delivery and baby was well discharged to mother.
What was the reason for instrumental delivery? Is it because maternal exhaustion? Because I don't see anything on a CTG.
So because of during this poor tracing times, there is evidence of fetal bradycardia down to 80 beats per minute. So the positions of.
Oh yeah, that's okay, because if you're concerned that you cannot interpret the CTG, it's always good to err on the side of caution and apply QE cup. That's absolutely fine. Tapi overall pattern sampai the loss of contact tu nampak normal CTG. And then there was some intermittent loss of contact. But in between tu, I can see dia punya baseline maintain kan. Lepas tu ada fetal heart rate tu naik to become tachycardic. You know, at that point, yes, there's something going on there that dia very quick intervention lah, that's okay. Tapi kadang-kadang tu kalau dah nak deliver tu, sometimes you get, you know, as the head is becoming visible at the perineum, you get a lot of loss of contact as well. And that one too is to be expected because the baby's heart has gone down, kan? The chest has gone down into the birth canal already and you can't pick up. So banyak kali judgement tu very clinical. Dah kat perineum, loss of contact, tak payahlah put a kiwi cup on. In fact, kalau dah ada kat perineum, I'll take the CTG off already. Prepare for, you know, skin to skin for a mom, and but it's okay. There's no right or wrong answer here. If you feel that, you know, you cannot interpret the CTG properly, err on the side of caution, get the baby delivered.
Right, okay. All right, so we move on to next case. Case number 10, primary gravida at 38 weeks plus 6 days, antenatal maternal obesity, come with spontaneous labor, sent to labor room with odds of 6 cm, ARM is clear liqua. So 4 hours later, she's entered to second stage. So this is a second stage CTG. So as we can see, the os fully is at this time around. So baby was delivered via spontaneous vertex delivery after 25 minutes. Deliver baby 3 kilos, but the ABGA score at 1 minute is 6, and however baby was well, was discharged to mother. Do you want to comment anything, Dr. Imelda, about the CTG?
Yeah, before the OS was fully, I was a bit concerned about that flat CTG variability reduced with some shallow decelerations there. But after OS to fully, and then bila kita tengok CTG seem to have recovered kan?
Yeah.
Dia dah bangun dah. That is why to make a decision for pathological CTG, you need a 30-minute trace. You cannot see for 10 minutes and kata pathological, and then sometimes your intervention can be too soon. So there are some criteria for pathological CTG, macam variability pun 50 minutes per, kalau abnormal feature seen in decelerations pun dia nak tengok, unless you have prolonged deceleration kan, deceleration feature which is of concerning feature, dia nak tengok 30 minutes baru jadi pathological. But in this case, this is just that, you tengok mula-mula the first 10 minutes tu, oh worry. This one kalau continue 30 minutes dah pathological kan. But it didn't continue. It picked up, variability had picked up. And that's baseline dia je naik, but it's about to deliver anyway. So cepat je deliver pun.
Okay, alright. Alright, so you almost, is it okay, Doctor? Another about three scenarios?
I'm okay, we are okay.
All of you okay, participant? Alright, so we move on. So case number 11, this patient, she is 31 years old, G2 para 1 at 38 weeks plus 1 day. So antenatally, she's having GDM on metformin 500 mg/d, multinodular goiter with subclinical hypothyroid, and also one previous untried scar. So she was induced with Foley and was sent to labor room as Bishop's score is favorable with os of 4 cm, and during that time ARM done is clear lipo. So after 5 hours in labor, os fully. So this is her CTG during second stage. So as we can see, about 1:30 p.m. os is fully. During that time, station is +1 with clear liqua and direct OA position and small capital with mounting grade 1. So she had been decided for vacuum assisted delivery after about 22 minutes in second stage, and baby was delivered well and was discharged to mother with no evidence of acidosis. So and anything, Doctor, want to comment about this case?
Yeah, so there was one episode kat situ. Is it based on that looks like a bradycardia ke? Heart rate dropped for about 4 minutes kan? 3 minutes.
It's about 3 minutes.
Yeah, difficult to interpret that one because you're seeing good variability during on the way down. So yang tu kadang-kadang sometimes you come across you termenung sikit. Ni betul ke deceleration ni? Ini betul ke bradycardia bila tengok variability so good? It could be, but then you tengok after that dia dah okay balik. So some people are very on top of things. They have their kiwi cup ready. Bila tengok macam tu je, it goes ding, 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 ding. And then doctor, Brady. And the response is, let's get the kiwi, which is absolutely fine. There's no wrong in there because you did not allow any further episodes. It's pasal dah deliverable anyway, kan? Dah station +1. Apa nak tunggu lagi kan? Tapi kalau decision has to be made, cesarean section, you kena take action by left lateral position, IV hydration, tengok dia recover ke tak. Then you are able to buy a bit of time to have a normal birth for the patient and reduce morbidity to mom for an unnecessary cesarean section. So yes, you got to have a balance. So kalau dah memang fully dilated, station +1, ada that sort of occurrence, you're already called, you're already there, you might as well get the baby out. So it's absolutely fine.
So then we move on to next case presentation. So case number 12, 30 years old, Gravida 3 para 2 at post-date plus 9 days. She was admitted for IUL in view of post-date and induced with Foley. So clinically, baby about 2.8 to 3 kilos and sent to labor room with os of 4 centimeter with clear liquor. This is her CTG after 4 hours in labor. During that time, os is 5 centimeter, cervix is effaced, station -1, membrane absent, clear liquor with LOA position with posterior asynclitisms. So from the polls, about 80% of participants is agreed with this CTG. Patient should underwent emergency lower segment cesarean sections. About 17% participant will do the hydration and put patient in left lateral positions, and about 2 participant will continue CTG monitorings. Okay, all right. So
So there is no wrong answer to that, because it depends on who you are. The first port of call who sees this is our midwife, kan, or our junior doctor. You cannot make decision for a cesarean section. So you got to call your senior to make the decision for cesarean section. And what you want them to do is put the patient in left lateral position, start IV hydration, and put the syntocinon on, and do the observations. What's the mom's blood pressure, heart rate, ada temperature ke tidak, kan? And then the decision will be made for cesarean section. I don't expect there will be a recovery from this sort of CTG. This CTG looks like it's been going on for a while. You don't suddenly become like this. So I think kalau you dah nampak this, sometimes you see a CTG that has not been has been pathological for a while but not been identified as pathological, and you come and see it's been going on for 2 hours like that, right? So at that point your decision is not the same as if it's just changed for 30 minutes and it has just become pathological. So if it just become pathological, you need to assess to see, can we correct this? Is this already failure to progress anyway? Kan? Kalau failure to progress, tak payah nak tunggu IV hydration, left lateral, just go ahead and do a cesarean. But when you do your VE, you will be able to make that assessment. Kalau they are making good progress, and this is just a change in the CTG, you still have time to see if you can reverse the process by stopping synto, put left lateral, IV hydration. Sebab tu when you tengok one CTG 20 minutes macam ni, all your answers are correct. But the main thing is you identify this is pathological and action needs to be taken.
okay. So how this patient is proceed with cesarean sections. So intra-op uncomplicated. However, her clear liquor is changed to light meconium stain. Baby with good up gas score and no evidence of acidosis, and baby was discharged to mother.
Yeah, so I say well done.
Yeah. And for those who are managing these patients. Okay, so last 2 cases, because I have one last CTG, which is special request from my colleague for these presentations. So second case.
Oh, mesti susah ni. Okay, let's pay attention.
Tak susah pun. So next case, 37 years old, G4 para 2 plus 1 at date plus 1. So she had 1 previous scar with 1 successful VBSC and was admitted for leaking. So she was sent to labor room as Bishop's score is favorable with os of 3 centimeter and our ARM done is clear liquor. So 10 hours in labor, was informed by staff nurse CTG is actually pathological. So during this time, the cervix is on vaginal examination os is 6 centimeter with stations -1, membrane absent, clear liquor, and no cord, no placenta. So from the polls just now, most of our participants agreed this is a fetal bradycardia CTG. About 9 of the participants said it is pathological CTG. 8 is variable deceleration with no concerning characteristics, and 4 of them said this is normal CTG. Right, so before that we will, okay, so what will happen to this patient is actually during that time the person who are attending this patient interpret this CTG as fetal bradycardia. So patients was proceed with cesarean sections during intra-op, LICOA is clear with good Apgar score with no evidence of acidosis, and baby was discharged to mother. Do you want to comment anything, Dr. Imelda?
She got to how many centimeters?
6 centimeter. From 3 centimeter, then after 10 hours, she's just progressed to 6 centimeter.
So was there failure to progress anyway?
Yeah, true.
Kan? How long it took? I mean, she from 3 to 6 centimeters in 10 hours, did you say?
Yeah, in 10 hours, from 3 to 6 centimeter.
So from 3 to, it could be latent phase dulu. Sometimes the first 4 hours is just shortening of the cervix, especially if she is a multi-os. So may not have started labor. So it doesn't mean to say 3 to 6 centimeters in 10 hours is too long if established labor has only started, 6 hours ago, So I would want to have a better information, like what was it 4 hours ago, not 10 hours ago. So it was still 6 centimeters 4 hours ago, then I'll say yes, this is failure to progress. But if you say in the last 10 hours was 3, maybe labor hasn't started then. So the issue is when you look at the CTG, I don't see anything abnormal right up to the point when it looks like there's loss of contact.
Yeah, true. Okay.
I don't see any fetal reading there. It looks like maternal pulse, and then in between tu is what we call doubling. CTG machine ni dia tak berapa pandai, as what I said before. If they cannot find a pulse, they'll find a maternal pulse. And then sometimes they try to make sense of it. I don't know what the term is called, but some machines double heart rates. And then you see that macam hilang and then tinggi balik. Hilang, turun balik. Hilang, tinggi balik. Hilang, turun balik. And none of it shows a sign, shows to me that it's bradycardia. Sebab apa ni, after that you get a pickup. That does not mean to say that it's a bradycardia. Tengok variability, dia normal. That is a change. That is not a normal, that is not the fetal. It might be maternal. It's very difficult to interpret that one. Okay. So, it's very unusual to have bradycardia from suddenly normal like that. Kan? And then hilang, langsung hilang. So the issue here is, well, if you did your cesarean section because of you've lost contact, you can't pick it up again, then you've not done anything wrong there. You've not done anything wrong, because if you cannot pick up fetal heart, you cannot pick up fetal heart, the only thing you need to do is do a cesarean section. Tapi, in hindsight, you can easily say that's not a bradycardia lah, because baby is fine, kan? But you cannot do that. If you are in that situation at that point, what would you do? Okay, so yang ni maybe kalau ada ultrasound at hand, you can see is there fetal heart or not.
Okay, all right.
Because sometimes there will be a certain occasion, if you have ultrasound machine right there, we cannot pick up fetal heart, and you doubt that there's bradycardia because you actually don't see fetal heart there. Then you put on the ultrasound probe. Oh my God, it's 40 beats per minute. That's why it's not picking up at all. And then you proceed with cesarean section. Sometimes you put on the probe and you find the place to readjust your CTG positioning of the toko, and then you find it. Tapi at the same time, okay, you're wasting time. You're wasting valuable time. It's actually bradycardia which you should be acting on. So that is why sometimes it's not right or wrong answer. you kena have a suspicion. Bila tengok CTG is absolutely normal before loss of contact, right? The ideal is to put electrode scalp. I don't know if people have that in their labor rooms, electrode scalp monitoring for fetal heart rate. Put that one on. That's the first thing I would do for that if you have it. Because you lose contact from abdomen, especially kalau mom is obese. That we know that mothers who have obesity have higher rate of cesarean sections, partly because of this poor contact, difficult to monitor, especially kalau tak ada scalp fetal heart electrode. So did you say what? Internal CTG, that's the fetal scalp electrode. Kalau with fetal scalp tak ada pick up, you gotta go ahead and do CTG, cesarean section. You tak ada, you don't have a choice.
All right. Okay. So last but not least, this is a CTG that requested by one of my colleagues for interpretation. So basically, the CTG is for one of our patients, primary gravida at 38 weeks. So she was presented with early labor with os of 2 centimeter. Antenatally was uneventful. So during this time, is the her os opening is cervical opening is about 2 centimeter. But from this CTG, as we can see, there is acceleration. However, with fetal movement, there is evidence of decelerations of the going down of the fetal heart rates. What do you think, Dr. Imelda, with this CTG? Should we continue the CTG or should we repeat the CTG? Or if Bishop said favorable, should we do the amniotomy for the patients?
Okay, dia punya define risk again?
She is primary gravida at 38 weeks, antenatally was uneventful, come with latent phase of labor with os of 2 centimeter, contraction about 2 in 10.
Okay, so do we know about fetal growth? This is the other thing. Sometimes if you have IUGR, kita ada threshold kita for intervention is different if we know a patient has IUGR or not. And then fetal movements also important. So bila kita tengok di CTG, I don't see this to be a normal CTG because of the variability overall. Makes this a bit of suspicious feature to me. 2 centimeter labor tak establish lagi. And you expect, you know, when labor is not established, do you see any contraction or not? There's no contraction there. Kan? So kalau labor tak establish lagi, tak ada contraction, I want to see accelerations in a 40-minute CTG. Now, this is a discretionary thing. This is not in NICE guidelines or in FIGO guidelines. But generally, there is some footnote to say an antenatal CTG or prior to intrapartum CTG, kalau tak ada contraction, right? You want to have normal variability and acceleration. Ni dah lama dah, 10, 20, 30, 40 minutes. So bila CTG macam ni tak ada contraction, variability is, to me, that is a poor variability. And this would be an abnormal antenatal CTG kalau tak ada contraction.
Okay. Right. Okay. Alright.
Tak ada contraction kan?
Tak ada contraction.
Nothing. So yeah, I wouldn't stop the CTG. I will not stop the CTG. I would want to continue with the CTG. I will want to know what her vital signs, make sure mom is well. And then from, even when you tengok CTG macam ni, I'm not happy to give prostin. I'm not happy to give syntocinon. Kan we have a criteria before you induce or augment with syntocinon. You must always have a normal CTG first. Bila tengok macam ni pun, I'm not happy to augment or induce unless the CTG becomes normal. So I want to continue the CTG for a bit longer before I make that decision.
Okay. All right.
But
Okay.
yeah, we're erring towards not inducing a CTG. That's definitely do not induce a CTG. That's not normal. So kalau dia ada prolonged latent phase macam ni, berapa lama you nak tunggu? Then you have to make a decision. Kalau decision, you got to make a decision, it will be a cesarean section.
Right. So with that, we have finished all of 14 cases today. I think this is very fruitful discussion today. We have so many cases have been discussed. Okay. Any questions from the participant? Any more questions? Any burning questions you want to give to Dr. Imelda?
Yeah, what happened to the patient? Betul, that's a good question.
All right, so eventually patient was delivered uncomplicated, normal delivery because
So
of
she continued to labor.
continue to labor. So we send to labor rooms and we do the amniotomy to her. Is clear LICWA. Then subsequently she's delivered.
CTG improved.
After that.
Yeah, CTG normal tak apalah, but don't stop that CTG. Basically that CTG is not enough. You need to have a normal CTG before you start syntocinon. You can ARM and see if the CTG will improve, and then she starts contraction to see if there's deterioration. But based on that CTG, do not stop the CTG and leave her alone. Secondly, do not give any prostin or start synto with that background of CTG. You gotta have a normal CTG before you stimulate.
Okay.
Yeah.
Some of the comment tu baby tidur tu daripada Mukri kan. Mukri kata baby tidur. Alright. Okay. Okay. So there is a question from Muhammad Imaduddin. So what do you think about amnio infusions in suspicious CTG?
Amnio infusion has been done under research. And it's not something we recommend out of research context. So it has been done in research for women with who already has ruptured membranes. So kalau tak ada ruptured membranes, no purpose of amnio infusion. And the reason behind it is cord compression can cause CTG changes. That is why changing position and IV hydration to improve amniotic fluid amount has been shown to improve CTG when the CTG has been pathological, partly because the studies that show when you put women in left lateral position, they find uterine perfusion improve and amniotic fluid also improve. Okay, and then when you start the IV hydration, amniotic improve and stays for longer. All right, which comes to the decision kenapa you buat ARM for no reason. Saat ni dapat cord compression, you have to put IV left lateral and IV hydration balik. Nah ni cakap pasal amnio infusion pula, right? So then you think, what is are you being practical if you do ARM for no reason? Because now you're talking about amnio infusion, okay? So that comes down to prevention of abnormal cord compression through making sure that when a patient is progressing normally in labor, jangan buat ARM unnecessary, jangan kacau. Because number one, right, one thing you can do is cause cord prolapse, cord compression, ascending infection and chorioamnionitis by so many unnecessary VEs, okay? So the first thing you want to do is, kalau you're thinking about amnio infusion, that means you're worried about cord compression from having done an ARM. So why are you doing ARM in the first place unless you're doing this for syntocinon? So the only purpose for doing ARM, if there is poor progress in labor and you're thinking of starting syntocinon for her, then we're going to do it, right? So studies of amnio infusion when you have a pathological CTG because of cord compression has been shown statistical significant improvement in the CTG and outcome of the baby, significantly reduced cesarean section rates. But this is the research setting, which is not practical in a normal labor room, because amnio infusion ni siapa yang buat? You cannot expect our midwife MO to buat amnio infusion. Ini fetal medicine level. Kan? You got to do it under ultrasound guidance, right? So there are two ways of doing amnio infusion. One is through the abdomen. The other one is done via the cervix. So you got to go past the fetal head and then get the infusion in. And then basically yang ni, there's risk of chorioamnionitis as well. So so far it's not been applied as practical. Tapi in academic setting, you improved your knowledge tremendously to know that, you know, kalau this is, you can see that amniotic fluid improves problems with cord compression, CTG, and cesarean section. Therefore, the most practical things you can take away from this is don't do unnecessary ARM if the patient is progressing normally.
Right. So there is one last question. Is there such thing a challenging with Pitocin?
Challenging what?
With Pitocin. I mean, maybe the CTG is actually abnormal. Then we challenge the baby with
Boy, kalau baby you sendiri, you tak akan agree to that. I said my CTG is pathological, right? Can you start me on Pitocin? Siapa agree? Angkat tangan.
Siapa agree? Any, my boss used to say make it or break it.
Yeah, well, you know, if you get away with it, you know, this is Pitocin stress test, you know, your number one, you've taken the oath is never to cause harm. If the CTG is already pathological, you're saying pathological, you not start symptom, why? Pathological means you need to take intervention already, take action. If the CTG does not recover with your left lateral position and hydration, and it remains pathological, you got to deliver. Why do you want to start Pitocin and cause more harm? And remember what I said to you about hyperstimulation. And remember what I said to you about reducing uterine perfusion reduces by 70% with a contraction. And that's the reason why you have hyperstimulation that can recover with the butylene. It's because you give the baby a break. Now you're not bagi harm by giving Pitocin. Then what happens if this baby then comes out poor? You can say pathological CTG, if you do the right things and the baby is born poorly, medico-legally, you have done your best. You've shown that you identified poor CTG, pathology, you have taken action, and then despite your efforts, you made an attempt to deliver. This baby comes out in poor condition. You're not at fault because you have, you know, your practice is, you know, crystal clear, defendable. Your practice is what recommended practice. But if you do something that is not evidence-based, not recommended practice, and baby comes out poorly, you kena gantung, right? You have caused harm because of, you know, an abnormal practice. Potentially syntocinon has been shown. We know syntocinon can cause hypoxia. We know syntocinon can cause harm. That is why we start syntocinon slowly. Kita kena start with normal stage. That is the prerequisite of starting syntocinon, is you must have a normal CTG. As soon as you go away from that, this is guidelines in all protocols. You go away from that, say pathological CTG, I nak start syntocinon. Okay, baby born poorly, you have no feet to stand on. Okay, but so it might be that baby will be born poorly anyway, whatever you do, tapi you don't cause harm. That's number one rule.
Right. So there is question from Wahida. She gave a scenarios of G2 para 1 at 37 weeks come in early labor with similar to case number 14 with os of 1 centimeter. So should we consider amniotomy or consider hydration and left lateral while ongoing CTG?
I don't get the question. I don't tengok. Asal punya soalan tadi dia kata cheap drug, expensive medical legal, and then I got distracted. What was the soalan?
So okay, the question is actually with the similar CTG with case number 14 just now. But this question is actually G2 para 1 at 37 weeks come in early labor with os of 1 centimeter. So what should we do, consider of amniotomy or just enough with hydration and left lateral position while ongoing CTG?
What is the difference? The difference is dia para 1, is it?
Yes, yeah. My case is para 1, this is G2. Para.
Why should that be a difference? You kalau CTG tu you kena tengok your management ni. Okay, what a lot of people tend to get caught up with ialah, oh, kalau dah pernah bersalin 3 kali, sayanglah kali ni kena buat Caesar. And we have seen bad outcomes with delayed intervention just because the mothers have given birth before, therefore should be a normal birth this time. But this time labor could be different. There could be cord compression. It could be a bigger baby. It could be, something else happening. And you cannot base your decision on mother's gravida berapa, para berapa. You have to take each baby separately, okay, assess the CTG, check progress, and make a decision based on that. So, para 3, para 4, previous normal birth, okay, bila you buat defined risk tu, sama aja. Para 1, primary gravida does not come into your defined risk. Defined risk tu is looking at maternal observations, poor obstetric history, meconium, pyrexia, IUGR, okay, hypertension, diabetes. These are the prolonged rupture of membranes, prematurity. These are all what we look in the defined risk, not the primary gravida or not.
Okay. All right. So from Dr. Rashida, from the last CTG without contractions. So let's say the CTG is normal afterwards with os of 2 centimeter. Do we let the labor is progress spontaneously or get the labor going to ARM and Outman with pitocin?
Okay, then you got to have a discussion with the patient. Latent phase can be quite stressful when it's prolonged. Some mothers have had 3 nights of no sleep. Even though a contraction happens every 15 minutes saja, every 20 minutes saja, right? If it's going on for 3 days and it's 1 to 2 centimeter and it gives the mother stress and she wants pain relief, okay? Then you have indication to induce labor for prolonged latent phase. But there is no right or wrong answer. Kalau the mom is strong, I said, well, it doesn't really bother me, I'm okay to continue. I don't want any induction of labor. You tengok CTG to normal. Then there is, if not found an indication to induce, then you can say, okay, you just do a cervical sweep and wait a bit. Tapi kadang-kadang you cannot provide that sort of service in a very busy hospital setup where you have 20 patients waiting to be induced and tak cukup beds, labor room full. So you got to play by that. Kalau labor room full anyway, kita tak boleh induce anyway. So, and the CTG is fine and mother's fine. Kata, tunggu kejap. Sometimes you allow patients who live nearby to go home and come back when the contractions are more frequent, or if there is leaking of liquor, there's bleeding or reduced fetal movements. But sometimes you, based on your judgment, you cannot allow patients home if she is far away, she relies on husband to take them to hospital, or you think she cannot make a judgment. Some patients, they are very they're quite intelligent. You can educate them when to come back. And there are some patients just do not understand. You can, on your discretion of the patient that you assess, if you feel that, it's not, dia tak sesuai to go home and come back, you gotta keep them in. And then depending on your labor ward situation, your staff and resources situation, whether you want to give time at mother's request to give time for labor to start naturally or not. But the only syarat dia is that you continue surveillance. You don't allow prolonged latent phase without any surveillance at all. At least you do your CTG every 2 hours or every 4 hours. And people asking her whether ada leaking, ada bleeding, and you do your observations kalau ada pyrexia atau tidak. So this ongoing surveillance must continue for prolonged latent phase if you're not going to induce, but you don't have to induce.
Alright.
So banyak soalan macam ni kan, is no clear-cut answer. You discuss with the patients, and then to have an agreement between you and your patient, right? To continue with the wait for spontaneous labor, ataupun to act with an induction of labor.
Alright. Okay, yes. Any questions from the participants? I think there's a last questions from Dr. Rashida. So before there is a small favor I would like to ask to all of you, because we want to take photography sessions. So before we end, I would like to all the participants to turn on their camera for photography sessions with our Dr. Imelda. Okay, ada 100, ada about 200, berapa page, banyak page nak kena buka ni. Alright, yeah. Okay, ready?
Assalamualaikum Dr. Imelda. This is Halina here.
Dr. Imelda, Prof. Hamiza.
Lama tak jumpa.
Buat pula.
Itulah bila kita nak buat masterclass balik.
Itulah. Nanti buat masterclass kita panggil semula. Ni COVID ni tak boleh pula nak buat.
Itulah kan, tak boleh. Now KKM nak buat decanting COVID patient for delivery pula.
Tak rezeki lah.
Kita dah lah kelam kabut.
Itu kira durian runtuh.
Apa dia?
Itu kira durian runtuh.
Nanti Sat
Thank you so much. InsyaAllah kita jemput lagi.
So very
thank you for the invitation.
Right.
Ambil gambar semualah.
Ambil gambar, Prof.
Ambil gambar.
Oh dah kah? Belum ambil lagi kah? Dah.
Betul rambut sikit noh, sikat rambut sikit lah. Penat dari tu.
Rambut I memang tak pernah sikat. Selalu kosot.
Alright, so with that, we will end our sessions with Tasbih Kafarah and Surah Wal-As. Before that, don't forget to scan your QR code for CPD points. So I will share, share my screen first. Where is my screen? Okay, sorry. Okay. All right, so with that, we'd like to thanks again to Dr. Imelda for a very fruitful discussion and spending your time this Friday evenings with us. So we hope for all the don't miss for our future sessions with many more experts, this will be a monthly program, Meet the Experts. And with that, thank you everyone. Have a great weekend and stay safe to meet again in next MTE. Thank you.
Thank you, Lisha.